concept was good. So they compared 660 gray in 2 gray diffraction to 52.5 gray in 2.60 gray fraction. Remember, these studies started early on before dose escalation studies. So most of the studies, the dose selected, were lower dose to start with. But the end results of these studies showed no significant difference between hypofractionated regimen and traditional or conventionally fractionated regimen of radiation treatments. So one study was done in Canada, NCI Canada, and the other study was done in Australia. And again, same conclusion that hypofractionation using two-dimensional treatments did not differ much compared to conventional fractionated radiation using peak refraction. Again, this technique is almost obsolete in many centers around the world. The second two studies, which is more contemporary, they use three-dimensional radiation treatments. And many of the cancer centers around the world are using three-dimensional treatments. And the study used higher dose, 80 gray and 40 fractions, versus 62 3.gray fractions with some androgen deprivation therapy. Again, the 5-year PSA control was similar between the studies. Again, the study from Fox Chase by Alan Pollack and the study from Emily Anderson looking at the same questions, and was Pollack, which was published recently. So basically, they looked at patients with low and intermediate risk of prostate cancer, but mainly low risk of prostate cancer. They randomized patient to 76 gray, 2 gray refraction, or 70.2 gray, 2.7 gray refraction. And androgen deprivation therapy was allowed only for 6 months, and the 5-year PSA control was 79 versus 77%, and the p-value was not significant. Based on that, we concluded that the study showed no difference between hypofractionated and conventionally fractionated radiation treatment regimen, and there is no much difference in toxicities. This is a randomized study, so what they did is they checked side effects at baseline, symptoms at baseline, and correlated with side effects after treatment at 3, 9, and 12 months, and even longer. They went after 36 months now. Currently, the RTUG is conducting 2 randomized studies. One is currently ongoing, and the other one, the 0415, was complete. And the study compared 73.8 gray in 1.8 gray refraction to 70 gray in 2.5 gray refraction. And the study is not reported yet. We anticipate the results hopefully this ASTRO or next ASTRO. And the Medical Research Council in England comparing 74 gray in 2 gray refraction compared to 57 gray in 3 gray refraction and 60 gray in 3 gray refraction. And the study is ongoing. Again, the results might take a few years to come up. Another study, again, comparing 78 gray to 60 gray in 3. So we can tell from all these hypofractionated studies that it is promising results, but we do not have long track records of how effective this fractionation scheme 5, 10, 15 years down the road. Another approach for hypofractionation is the extreme hypofractionated regimen, where we use only few fractions of radiation treatments. Because of the factors we will discuss in a minute, SBRT or stereotactic body radiation treatment became a routine option for patients with localized prostate cancer. And this became a routine option because of advanced in treatment planning. We have a very, very robust computer system and treatment planning systems. We have an excellent radiation treatment delivery system. We can deliver a very high dose in a very, very short time. We have excellent image guidance systems for prostate cancer patients. All these three factors must be available together to enable us to deliver extreme hypofractionation. If any of these factors is not available, the results would not be as good at all. So a larger fraction size can cause significant morbidity. No doubt, if you miss a prostate and you get the anterior rectal wall, you will end up with major disaster. So before we do SBRT, we must establish a system for IGRT or image-guided radiation treatment. And you give an example about how this will help us and why this is important. An institution in Texas, University of Texas in Dallas, so some of the studies used 10 gray refraction or 9 gray refraction, and we reported that doses more than 9.5 gray refractions were reported to have increased rectal toxicity and colostomy. And if you look at 1 month after radiation treatment, there was a rectal ulcer in the anterior rectal wall, and this ulcer basically increased in size at 3 months. What that means is these patients are at high risk for colostomy if you are not careful enough to track the prostate motion and avoid the anterior rectal wall. We're all aware of the therapeutic curve and therapeutic gain. So one way of improving the therapeutic gain of any treatment, including the radiation treatment, is to reduce side effects. The other gain, you can do it by increasing efficacy of treatments. So for radiosurgery, we know radiation works. It's very effective. But how we can mitigate or reduce side effects by reducing rectal toxicity? The word is IGRT. You must have IGRT. I'm going to devote some of my slides to talk about IGRT in prostate cancer, because in my mind, you cannot do effective and safe hypofractionation or SBRT for prostate cancer without a good and robust IGRT program. So IGRT significantly improves therapeutic gain by reducing the rectal tissue included in the radiation fields, and IGRT made it possible for us to increase the dose, and again, safely increasing the dose, and of course, translate into better quality of life and better therapeutic gain in our patients. So just a few facts about prostate motion that many of us might be familiar with. So prostate is a moving target inside the body, and it moves normally with rectal filling, bladder filling, and even normal breathing. The motion of the prostate is studied extensively and showed that the motion anterior, posterior, and sup nth is basically significant. That could be in a median of ½ centimeter. In fact, the range of this motion could be up to 1½ centimeter. So 1½ centimeter motion of the prostate means that if you add a centimeter margin around your prostate and the prostate moves 1½ centimeter, you will definitely miss it. And the patient will end up getting the side effect without any benefit from the treatment. So you must account for this organ motion for your daily treatment, especially if you are doing hypofractionation. So how we can track the prostate motion, how we can study it. So you can implant fiducial marker in the prostate. You can use cone beam, which is a miniature CAT scan you can use daily for treatments. You can use the GPS system or Calypso system. You can use 3-dimensional ultrasound, transperineal or transabdominal. The one we use in our institution is the Calypso system, which is a GPS system for prostate cancer patients. I'm going to quickly go over this system to show you how robust this system is. So what we do is before radiation treatment, we implant 3 markers inside the prostate, either by us or by the urologist or by the radiologist. And these 3 markers are not just fiducial marker or gold markers. It is wireless electromagnetic transporters that get activated by the radiation beam. So the way the patient will be supine in the machine, and the panel for the detection is basically placed on the stomach of the patient. Again, as you see, the patient has the marker inside the prostate, and the operator is basically adjusting the detector on the patient to make sure the system pick up the signal. Just FYI, if you have an obese patient, the panel of detection might be more far away from the markers, and it may not pick up the signal, as if you have a phone line with a very weak signal. So for obese patient, we cannot do this system because the system cannot make weak signal. And then the system also is recording the organ motion in the prostate during treatment and after treatment and before treatment. As long as the patient is still under this detector, we can record the motion of the prostate effectively. So this gives us the advantage of detecting the prostate motion before treatment, during, and after treatment, what we call intra-fraction motion. This is the only system available in the world as of now to track the prostate during the actual treatment. And in fact, we are developing software now, so the system could allow us to interrupt the treatment if the prostate goes beyond the margins that we are designing upfront. So in reality, the detector will pick up the signal, and the detector activates the markers inside the patient. The markers basically fire some electromagnetic signals that is detected by the detector, and this will go all the way outside to the tumor panel control. We see the graph, we see the motion of the prostate, how millimeter, in what directions, even the angulation of the prostate during delivery, we can study. So because of this many available tracking system for prostate, it is very difficult to ascertain which system is better for your institution, for your machines. You have the ultrasound system, you have the Calypso system, you have the cone beams system as well. So what we did at Henry Ford is to do a prospective study to compare the three systems together in the same patient to see actually what system could be more beneficial to the patient. And this study enrolled 45 patients and was recently published in the Medical Physics Journal, showing that the reproducibility and the accuracy is the best with Calypso and cone beam CT. Keeping in mind that Calypso is an invasive procedure requiring us to put markers inside the patient. So if the patient is taking anticoagulation for any reason, you may not be able to put the Calypso in. So CAT scan or cone beam CT might be a good alternative. The other evolving concept in image-guided radiation treatment is a spacer at the prostate rectum interface. As we can all see in this diagram, that the high dose region of the prostate includes part of the anterior rectal wall. And this is where we get side effect from. We get rectal bleeding, we get colostomy for high dose rates or extreme hyperfractionation. So in theory, if we are able to put a spacer between the anterior rectal wall and the prostate, then we can give us a space that we can play with, a space that we can buffer the dose of radiation away from the rectal wall. So this is in theory a good idea, but how we can do it? So this is another diagram to show that if you put the spacer between the rectal wall and the prostate, you can create a space so the high dose rate for prostate will not get into the anterior rectal wall. So this is actual patients where we put polyethylene glycol hydrogel through interventional radiology in between the rectum and the prostate. So the radiologist was able to kind of space this gel between the rectum and the bladder, the prostate. And you can control how much gel you can insert. You can insert up to 1.5 centimeter of gel. And this is what you need. Actually, you need only 1 centimeter, maybe 8 millimeter of gel. And this can be seen in, on MRI. You can be seen on a CAT scan. But the good news about this gel is it is biodegradable. It disappears by itself after 3 months. So it would not last after the course of radiation is over. So this is an advantage that we did over the last, I would say, 6 years, and becoming routine in some institutions, especially if we are using high fractionation or a high dose per fraction or extreme hyperfractionation. The other way of doing the IGRT is to use daily insertion of rectal balloon. So this rectal balloon will display the rectal wall away from the radiation field, but it will push the anterior rectal wall far in. But the good thing is it will push only a small portion of the rectal field inside the radiation field and displace the rest of the rectum away from the radiation field. So again, this is external beam. How about particle treatment? Proton. The Bragg curve, the Bragg peak. We all know that the proton or particle radiation treatments, we can control where the beam can stop and we avoid the tail of the radiation field. So this is just an example of the proton beam and IMRT showing that the dose is more conformal with proton beam compared to IMRT. And in fact, with proton beam we have the scanning and the scatter technology. And with a pencil beam on the right, the dose is even more conformed around the prostate. We are working on IM proton therapy. So IMRT now are using intensely modulated proton therapy. And you can see the dose is more conformed around the prostate. So all these advantages of technology are helping us improving the therapeutic gain of radiation treatment for prostate. We can also increase the dose or dose escalated and shorten the treatment time by using only 4 weeks of radiation from outside and boost the prostate with seeds implant, put some seeds inside the prostate, or put high dose rate catheters so the patient can get done in 5 weeks. How about biological dose escalation, which is my personal interest in our institution? So in our institution now, we are doing a program for biological dose escalation, where we use something called triple therapy. We use oncolytic viral therapy, suicide gene therapy, and radiation therapy. So what we do is injecting the patient's prostate with adenovirus containing 2 therapeutic genes. This is first step, and we'll do that like 3-4 days before. And then the patient will receive an oral proactive, like inactive medications, like chemotherapeutic agents, completely inactive, that will be active with the presence of the gene. And then we'll do radiation treatment a week after that. So by doing this triple therapy, we were able to show that the gene therapy in prostate cancer can escalate the dose and effectively reduce their failure rate, local recurrence, without increasing any toxicity from that. And we are basically embarking on randomized now. So we published the first prospective randomized study for patients comparing gene therapy with triple approach to radiation treatment alone to 80 gray and 2 gray refractions. And the study was published like 2 months ago showing that the biological dose escalation is feasible and very effective. So what we would recommend as of now is 79 gray and 2 gray refraction, 1.8 and 44 treatments. We use IMRT and we use daily image radiation treatments with cone beam or lipstick. And this is an example of the dose distribution around the prostate, showing that the 100% isos line is highly conformed around the prostate. So in conclusion, data from level 1 evidences established the role of prostate radiation dose escalation around 78 gray and 2 gray refraction. Due to many factors, hypofractionated regimens are appealing, especially with strict IGRT protocols. Extreme hypofractionated regimens for 8 gray refractions, 9 gray refractions, for 5 fractions are promising, but long-term level 1 results are needed. Thanks for your attention.
I'll be back here in Cairo to meet the friends and colleagues. I'll be talking today about, and also I would like to thank the organizing committee for Dr. Bragg and Khalid Kamal for inviting me to this important meeting. I'll be talking about a topic in testicular cancer that is seminoma, mainly stage 1, and to find a little bit the difference between the outcome in Muslim countries and in the developing countries like in Jordan, and to see the effect of cancer actually in both the international and also the local region here. So the testicular cancer, it is there has been an increase, 60% increase in the incidence in the United States from 1973 to 2002, mostly the seminoma, and during 2014 about 9,000 cases of testicular germ cell tumor will be diagnosed, and how of them are seminoma. And luckily for seminoma, 85% of them will be diagnosed as a stage 1, and this is the core of the talk today about the seminoma stage 1. Now in Jordan we have around 40 to 50 cases of seminoma per year, and there has been no change in the trend of the testicular seminoma in the last almost 15 years. We noticed some change in the trend with the prostate cancer, as I mentioned in my comments. That was the number 6 most common, now it's number 3, and bladder cancer back in 1996 it was number 1, now it is number 4. So there are some changes in the trend of the cancers in Jordan, but for the testicular seminoma is number 1. Now before going to the options of the treatment of seminoma, may I ask the audience if you have patients with the testicular seminoma stage 1, that how many of you will advise for adjuvant radiotherapy? Only? Okay. And what about active surveillance? 2. Active surveillance. Again, right. And carboplatin, non-cycle carboplatin? Again, yeah. Okay. So we know the options now for the stage 1 seminoma, that either the active surveillance, adjuvant radiotherapy, and also the adjuvant chemotherapy, single agent carboplatin, after the Oliver data that presented in 2005 and again in 8, and now it's in the NCCN guidelines to consider and the carboplatin as one of the options for treatment of seminoma stage 1. Now the question is, do we really need the adjuvant therapy, knowing that the active surveillance, even the patient that will have a local recurrence, probably the treatment, we have a very effective treatment, and we can reach 100% the survival even after having a relapse. Now the key goal for any modern therapy is to reach this actually statement that reduce overall burden of the disease and the treatment and maintain the excellent results. Now we know the Lance Armstrong, the story that he was diagnosed with the testicular cancer seminoma with metastasis, and he was cured, and also he was a champion even after the treatment. So really for the testicular seminoma, our aim should be to cure the patient and not really to think about any palliative measures. Now, coming to the first option, that is the adjuvant radiotherapy, why to choose and why not to choose the others? It was the standard of treatment for the past 50 years. And we know the relapse rate is between 0.5 and 5% only, and hardly any patient can die even if they have a relapse. And usually the relapse sizes are away from the parotid lymph nodes, usually with the thymus, superclave, and lungs. And chemotherapy is, in most of the cases, especially if the tumor size more than 3 or 4 centimeters, the chemotherapy can give an excellent salvage for those who relapse. Now, why I keep this in red? It's not red here, it is here in red. The second one, that's the relapse rate, 0.5 to 5%. And here is the change in culture between the Western countries and between the developing countries. Namely, I give an example as in Jordan. Whenever you sit with a young man, usually with a seminoma, and talk about the 3, we at King Hussein Cancer Center in the multidisciplinary clinic, the 3 options are there, and we, without bias, discuss with the patient all the 3 options, and with the pros and cons of each and every one, including the rate of the relapse in radiotherapy that's less than 5%, usually between 0.5 and 5. And surprisingly, most of our patients, 98% of our patients will choose radiotherapy. This is just in contrast what is there in the Western countries, namely in US or in Canada, in which 98% will go for active surveillance. They will not go for radiotherapy or go for the carboplatin. And when you discuss with them the anxiety about having a local recurrence, which is, we know that between 15 to 20%, they don't want that to take that risk of having a chance of relapsing in 15 to 20%, and again to go with for radiotherapy or for chemotherapy. And here is the change in the culture actually. Now, even though that we know that cause-specific survival is more than 99% in such cases. Now, these are the trials that we know the most important that changed our practice for seminoma for the last few years. The TE10 that compared the biotic radiotherapy with the doublet, as we used 10 years ago to consider not only the biotic lymph nodes but also the ipsilateral pelvic lymph nodes, and we know that it is the same. So we stopped for the last 7-8 years considering the doublet radiotherapy, and now it's only if radiotherapy to be considered, it is just with the biotic lymph nodes. And the dose again from the TE18 study showed that the previous one, the 30 gray, compared with the 20 gray, is the same. So again, for the last many years, now everybody is practicing or considering 20 gray rather than 30 gray. And by that, of course, we reduce the side effects, acute and late. Now the TE19, which started by Oliver actually, that compared the carboplatin with one cycle with radiotherapy, and again showed the same results, although the pattern of relapse was different. Now, if the adjuvant therapy have excellent outcome, then why to go for surveillance? We know that we are over-treating. If we treat everybody with seminoma stage 1, we are over-treating 85% of patients unnecessarily for no good for them. And also, there are some side effects from the radiotherapy and for chemotherapy, either acute or late. Although we don't know so far the late side effects of carboplatin, we have to wait more years to compare it with radio. Already we know the early and also the late, namely second-induced cancer, which is like 2.6% more than general population. Now, even with the survival, with the surveillance, if we keep the patients of the surveillance, you will see the chance of relapse, we know, is about 15 to 20%, but still, if you treat those patients, the cause-specific survival can reach up to 100%. So why not to go for active surveillance and not to go for treatment? Now, if you see the trend in Canada, because most of the testicular cancer studies are done in Brussels Market Hospital and Royal Marsden Hospital, and you can see here Brussels Market Hospital experience from 81 to 2004. Back in 80 to 94, radiotherapy was given to 95%, like Jordan nowadays. But nowadays in Canada, it is only 4%. And here is the change in culture actually. If you are unbiased and discuss all the options for the treatment for the young patients, then you will have the response from them. So it takes from them many years really to change to active surveillance if they discuss with the patients. Now we know this is again that the local recurrence is more with the active surveillance, but still you can salvage them with chemo, with radio, and you can cure them. Now, the problem with radiotherapy is that you are over-treating, or the number of the treatments more, because some of them will relapse on radiotherapy in less than 5%, and you have to consider chemotherapy for them. And for the survival, patients on survival arm, 15 to 20% will ultimately fail, and then you would consider chemotherapy for them. But still, the number in the arm of radiotherapy with the treatment is more. So to conclude, for the active surveillance, it is safe actually, effective, and leads to decrease in the treatment burden. And this is good for news for the patients to know that only orchidectomy is enough for them, keeping in mind the good compliance, and they should come for a follow-up. And if we know this from this information from the mid-1990s, why so far we have a debate now in 2014 which way to go? There is a lack of consensus. This, if you see in the coming few slides, a questionnaire sent to many physicians that treat seminoma or testicular tumor in general, urologists, medical oncologists, and radiation oncologists. And you can see, and this is actually from Europe, and there is another one from USA. And you can see only around 58% they will offer only one option. So if you have a patient and you offer him one option, probably he will go for that option. If he sees a radiation oncologist, probably he will go for radiotherapy. If he sees a surgeon, maybe he will just be in follow-up. Or medical oncologist probably will consider for carboplatin. So there is no consensus in general, even in Europe and USA. And only 21% they offer 3 options. And we in Jordan, actually, we offer, according to the NCCN, according to our knowledge about the outcome, that we unbiasedly offer all the 3 options. You see, in Europe, it's just 20% of them. That's why there is, you will find a lot of differences between the specialists and between the countries if you look about the options of the treatment for testicular cancer. Now, this is again to show that sometimes we act on our biases. Now, this from US questionnaire was sent to about 500 radiation oncologists. You can see here that most of them actually they preferred radiotherapy to consider adjuvantly and not active surveillance. And 33% of them, they had some concerns about the non-salvage at relapse on survival. That patients, if we make able survival, they become really with large relapses, and probably we cannot salvage those patients. And most of them, they were aware about the late side effects of radiotherapy, namely second-induced cancer, but still 85% of them underestimate the magnitude of this problem. So there is a variation as well. Now, can we have a risk-adaptive approach that some of patients really, we go strongly with adjuvant treatment and some of them just give on active surveillance? Many studies have been done on this, and in a work from Blessed Market Hospital published in 2002, the data that all we used to discuss about the 2 important only prognostic factors now, namely the size of the tumor, whether it is more than 4 centimeters or less than 4 centimeters, and the other one is about the reed testis involvement. But again, from the same Princess Margaret Hospital, Peter Chen published recently, 2004, that probably only the size of the tumor that matters and not the reed testis involvement. And you can see here the percentage of relapses as the size of the tumor increases. So now we may consider only the size of the tumor. That's really something to keep in mind while discussing the options with the treatment. You can see here we don't have that predictors really very strong to lead us to which way to go out of this 3. Maybe only the size of the tumor that can be kept in mind. Now, even in the active surveillance, we have really to be sure that to try our best, if we have a low CT, to consider low CT scan for the routine checkup for these patients, and not to use the ordinary one, although many of us actually we don't have a low dose CT scan. And we know actually the quality of the low dose CT scan is not like the usual one that we have, but still, it's, you can 99% of the patient you can detect any abnormality in that. Now, coming to the trust study of the MRC TE24 that tried to compare the CT, the number of the CT scan, how often you have to do patients on active surveillance, is it the 3 times or 7 times? Should you do annual one right from year 1, or you do it 6 monthly up to 3 years and then do annually up to 9 to 10 years? And actually in this, it was found that if you do it earlier, if you do it every 6 months, probably you can pick up the lymph nodes or recurrence in the pelvic lymph nodes, namely in the parotid lymph nodes and the pelvis, with a small tumor rather than keeping just in 1 year, because the size of the tumor will be more than 5 centimeters. So the practice now actually to do it every 6 months to do the CT scans, and namely the abdomen and the pelvis, because there is a question mark about the chest, about the efficacy of doing chest X-ray or CT scan for the chest. Most of the patients will recur, patients on active surveillance will recur in the abdomen and in the pelvis. Now, what about the tumor markers, the value at the chest X-ray? This is again some publication really did not support our routine use that we do in our practice by chest X-ray or CT scan of the chest. Like in one study, just one patient was diagnosed with a positive chest X-ray out of 75, and even the tumor markers, 11 out of 75 were raised. Now, this is actually the schema of the Princess Margaret Hospital that they use in Canada for seminoma stage 1. Usually, the CT scan every 6 months, up to 3 years, and then annually, and that is only if these are the first 3 years positive, negative for any metastasis, or no evidence of disease. They go for only abdomen and no pelvis and no chest CT scan. Of course, maybe most of us, we don't practice this, but this is what they do because they have the large experience in that. Now, management of the relapse on survival, usually it is by chemotherapy, by PEP chemotherapy, although some of the cases, if you have less than 3 centimeters in the para-aortic, radiotherapy goes up to 35 degree can be really effective in that. Most of us, more than 4 centimeters, will not really consider radiotherapy, but they go for chemotherapy. Now, this is just to show you the patients on active surveillance and why sometimes it's not really a routine to do a CT chest or X-ray, because most of the patients that they relapse, about 64 patients, most of them they had in the para-aortic lymph nodes, and para-aortic and pelvis, and 5 patients they have in pelvic, and none of them in the mediastinum or the testis, just one distal metastasis, and that's why they question the efficacy of doing CT chest in these patients. Now, whether chemo or radio, we know, as I mentioned, that less than 3, it is good to mention radiotherapy, because sometimes in chemotherapy you may have a problem with the side effects, and like in this trial, 2 cases had an MI from chemo and 1 cerebral fracture and 1 death, and the other report also 3 out of 76 patients with advanced seminoma died on treatment. This is actually, I'm showing one of my patients that I lost, the only one for the last 12 years that we lost at King Hussein Cancer Center. This patient who was diagnosed, young patient, 24-year-old, with testicular seminoma stage 1, tumor markers were normal, and CT scan before orchidectomy was normal, orchidectomy was done. He was offered all the 3 options back then, and he chose to go for radiotherapy as the other patient. And just 6 months after the para-aortic lymph node, this patient had the back ache. And when we do a CT scan for his the pain in the back, actually we found this was the normal one, and after 6 months we had this para-aortic lymph nodes recurrence attached to the source muscle, and that was the cause for his back pain. And actually, this patient had a very bad disease that we tried everything for him, and he is the only patient that we lost, unfortunately, that the chemotherapy, the bone marrow transplant, after 3 years from all the lines of chemo and the BMT, we failed, and he is the only one out of 80 series that we published that we lost this patient. So the optimal strategy in stage 1 seminoma, just to conclude, probably we should think really in this part of the world, why not really to consider the active surveillance rather than although, and what are the ways to change the culture of the fear from the local recurrence and the fear of the chances of having chemotherapy later on. We know the active surveillance in most of the patients can be salvaged even if they have local recurrence. Thank you so much.